Alright, so we're going to go over the pancreas and we're going to go over certain information about normal pancreatic anatomy and certain pancreatic abnormalities that might be noted. So we can go over some key terms. So the acinar cells are the cells of the pancreas that carry out the exocrine function to produce amylase, lipase, sodium bicarbonate, and other digestive enzymes. An annular pancreas is a congenital anomaly of the pancreas that results in a maldevelopment of the pancreas, developed in such a manner where the most ventral part encases the duodenum. Chronic pancreatitis, recurring destruction of pancreatic tissue that result in atrophy, fibrosis, and scarring. Cystic fibrosis, this is an inherited disorder that can affect lungs, liver, pancreas, and other organs. The double duct sign is consistent with enlargement of the common bile duct and the pancreatic duct. The duct of Santorini is the accessory duct of the pancreas. The duct of Wirsang is the main pancreatic duct. The duodenum is the first segment of the small intestine, and endoscopic retrograde cholangiopancreatography is a fluoroscopic procedure used to evaluate the biliary tree and the pancreas. A gastrinoma is an islet cell tumor found within the pancreas. Hyperamylasemia is an elevated amylase count. Hyperparathyroidism is the presence of elevated parathyroid hormone. An ileus is a bowel obstruction caused by a lack of normal peristalsis. And insulinoma is an islet cell tumor found within the pancreas. The islets of Langerhans are small islands of tissue found in the pancreas that produce insulin and glucagon. Islet cell tumors are tumors found within these islets of Langerhans. The lesser sac is a peritoneal cavity located between the stomach and the pancreas. It's a part where fluid can accumulate. The pancreatic adenocarcinoma is the most common form of pancreatic malignancy. Pancreatic BVSM is a congenital anomaly of the pancreas that results in a shortened main pancreatic duct, and it only drains the pancreatic head and not the entire pancreas. A pancreaticoduodenectomy is a surgical procedure in which the head of the pancreas, the gallbladder, and some of the bile ducts and proximal duodenum are removed because of a malignant neoplasm. It's also referred to as the Whipple procedure. A pancreatic pseudocyst is a cyst surrounded by fibrous tissue that consists of pancreatic enzymes that have leaked from the pancreas. A phlegmon is a pancreatic fluid collection that results from an inflammation of the pancreas. An acinate process is a posterior medial extension of the pancreatic head. And von Hippel-Lindau disease is a hereditary disease that includes the development of cysts within the pancreas and other organs. Zollinger-Ellison syndrome is a syndrome that includes an excessive secretion of acid by the stomach, and this is caused by functional gastrinoma in the pancreas. Next, we can move on to anatomy. So the pancreas initially develops in two separate parts that eventually fuse together to constitute one kind of truncated cone. And the pancreas is located in the epigastrium between the C-loop of the duodenum and the splenic hilum. The pancreas consists of four main parts. It has a head, a neck, a body, and a tail. And in some individuals there exists a posterior medial extension of the pancreatic head, and we refer to this as the ocinate process. Although some of the pancreatic head may be covered by peritoneum, the pancreas is considered to be a retroperitoneal organ, and it has both exocrine and endocrine functions. It has exocrine function in so much that ducts are used to transport digestive juices, and it has an endocrine function, that is, it releases hormones directly into the bloodstream. The exocrine function of the pancreas occurs through amylase, lipase, sodium, and trypsin. So amylase digests carbohydrates and converts starch to sugar. Lipase digests fats and converts fats to fatty acids and glycerol. Sodium bicarbonate neutralizes stomach acid. And trypsin, chymotrypsin, and carboxypolypeptidase are proteases. These digest proteins. The endocrine function of the pancreas includes the alpha cells, which produce glucagon. They promote the release of glucose by the liver, and they increase the blood sugar level. The beta cells produce insulin and stimulate the body's use of glucagon. And the delta cells produce somatostatin, which restrain insulin and glucose levels. The acinar cells of the pancreas carry out the exocrine function, and the accessory duct, the duct of Santorini, is a branch of the main pancreatic duct and has its own separate sphincter into the duodenum. So from the main pancreatic duct, the enzymes collect into the ampulla ovata, and at this ampulla, pancreatic digestive enzymes are mixed with bile from the liver and released into the duodenum. This opening that allows the release is called the sphincter of Oddi, and it is triggered by cholecystokinin release by the duodenum as a result of the presence of chyme. Therefore, cholecystokinin causes a simultaneous contraction of the gallbladder and relaxation of the sphincter of Oddi, and the breakdown of various food products. So the endocrine function of the pancreas is performed by the islets of Langerhans, and it is composed of alpha, beta, and delta cells. The islets produce vital hormones, including insulin and glucagon, and they are released directly into the bloodstream. Glucagon promotes the release of glucose by the liver, which in turn increases blood sugar levels. Insulin stimulates the body to convert this glucagon to glucose. The arterial blood supply to the head of the pancreas is via the gastroduodenal artery, and the body and tail of the pancreas receive their blood supply from the splenic and superior mesenteric arteries. The venous drainage is achieved by means of the splenic vein, the superior mesenteric vein, inferior mesenteric vein, and the portal vein. So on this image here, we can see the pancreas and surrounding anatomy. So we can see the celiac axis over there. We can see the duodenum, and we can see the gallbladder in relation to the pancreas. We can see the proper hepatic artery. We can see the common bile duct. We can see the left gastric artery. We can see the left kidney, and it is on the other side. There's the left kidney. We can see the main portal vein over there. We can see the splenic artery over there, the superior mesenteric artery over there, and we can see the spleen. We can zoom in here and we can see the relation of the biliary tree to the pancreas. So within the pancreas, we can see that there is the pancreatic duct, which joins the common bile duct at the ampulla ovata, and there's the pancreatic duct. You can also have an accessory pancreatic duct that has its own opening into the duodenum. So, sonography of the pancreas. Um, so rarely the pancreas is imaged without including a complete right upper quadrant view. So the pancreas is frequently neglected because of the challenge it presents for sonographers, but it can be found. Adjacent bowel, gas, and body habitus are two obstacles that are usually encountered. And to improve visualization of the pancreatic head, patients can be asked to drink a small cup of water, and the water, once in the C-loop of the duodenum, will provide a delineated view of the pancreatic head in most individuals. Additionally, we can employ a left lateral decubitus position to help improve visualization of the pancreatic head. And to better visualize the tail area, you can scan through the left kidney to the spleen in the right lateral decubitus. Or we can have upright scanning. So the pediatric pancreas may appear more hypoechoic due to a lack of fat surrounding it. The anterior structure of the pancreas is the gastroduodenal artery. The more posterior structure is the common bile duct. And depending on the resolution of the ultrasound system, the normal main pancreatic duct may be noted during a routine sonographic evaluation or examination. It will appear as an anechoic tube consisting of two parallel lines and an anechoic lumen. The anterior-posterior diameter of the main duct should not exceed 2 millimeters. We can also employ color Doppler imaging, and we typically measure the pancreas in AP dimensions, and normal measurements of the head and body are between 2 and 3 centimeters, while the tail should measure between 1 and 2 centimeters. So the relations to the pancreas include the pancreatic head, the pancreatic body, and the pancreatic tail. Posterior to that, the pancreatic body, we have the aorta, we have the superior mesenteric vein, and the splenic vein, all posterior to the body of the pancreas, as well as the eosinate process. Inferior to the head, we have the inferior vena cava and the right renal artery. Yes. Congenital anomalies of the pancreas. The two most common are pancreatic divusum and an annular process. Pancreatic divusum is the most common congenital variant, and it results from abnormal fusion of pancreatic ducts. Divusum results in a shortened main pancreatic duct, and it drains only the pancreatic head. And the accessory duct of Santorini, which is much smaller than the main pancreatic duct, is therefore forced to drain the rest of the pancreas, and it empties a larger amount of pancreatic juices through the minor sphincter. And this abnormal duct arrangement causes a functional obstruction, and there is a lack of proper drainage, increasing the risk for pancreatic inflammation. Individuals might be asymptomatic, and the annular process would result from maldevelopment of two embryonic elements, right? The most ventral part of the pancreas, which encases the duodenum and may lead to duodenal obstruction. So here we have pancreatic divusum result in a shortened main pancreatic duct. And an annular pancreas results from maldevelopment of the two embryonic elements of the pancreas. We can have acute pancreatitis, and this is inflammation of the pancreas, secondary to the leakage of pancreatic enzymes from acinar cells to the parenchyma of the organ. and these juices destroy pancreatic tissue. We can classify pancreatitis as mild, moderate, or severe. And the most common causes of acute pancreatitis are alcohol abuse and biliary tract diseases. Patients will typically complain of abdominal pain, back pain, some leukocytosis, have elevations in blood glucose, as well as elevations in lipase. Sonography is not always successful at diagnosing cases of acute pancreatitis, and this is because the pancreas might appear completely normal, but diffuse enlargement of the gland can be seen, and most likely the entire pancreas will become enlarged and hypoechoic. So clinical findings include elevated amylase, elevated lipase, leukocytosis, elevated ALT and other liver lab values, abdominal pain, back pain, fever, nausea and vomiting, and severe acute pancreatitis. Sonographically, the pancreas may appear normal, or it might be diffusely enlarged with some hypoechoic areas, or there might be a focal hypoechoic area. The pancreas might be unencapsulated with an anechoic fluid collection, and we call this peripancreatic fluid. We can have pancreatic pseudocysts, they can be abscess formation, biliary obstruction might be present, and you can have vascular complications such as splenic vein thrombosis or pseudoaneurysms of the splenic artery. And in this case, this is a diffuse acute pancreatitis, and a transverse image, and we can see a hypoechoic pancreas. Also seen in this image are the portal confluence, the superior mesenteric artery over there, the aorta, which are posterior to the portal confluence, and the liver, which is in this case superior, well, anterior to the pancreas in this case. Chronic pancreatitis is a repeated bouts of pancreatic inflammation. Not all patients who have a history of acute pancreatitis will go on to develop its chronic variant. And although many patients may be asymptomatic, they may present with some persistent epigastric pain, some jaundice, some back pain, some anorexia, some vomiting, some weight pain, or some constipation. Calcifications can be noted throughout the parenchyma of the organ, although they may be confined to the pancreatic ducts, and this in turn can lead to biliary dilatation. So sonographically, we would see a heterogeneous hypoechoic atrophic gland with poor margins. We can see calcifications within the gland and some pancreatic pseudocysts. There would be a dilated pancreatic duct and possible portal splenic vein thrombosis. We can move on to a pancreatic adenocarcinoma, and this is referred to as a pancreatic ductal adenocarcinoma. It's the most common primary pancreatic malignancy. This disease often presents late and is quite difficult to treat when it is discovered, and as such, it is the fourth most common cause of cancer-related deaths. Recall that the Courvoisier gallbladder describes the clinical detection of an enlarged palpable gallbladder that may be caused by a pancreatic head mass, and in this case, this would be the mass that might lead to Courvoisier gallbladder, and the mass might be a pancreatic adenocarcinoma. So sonographically, the most common appearance is a hypoechoic mass in the head of the pancreas. An obstruction of both the common bile duct and the pancreatic duct may be present, and we call this the double duct sign. The liver and other abdominal organs should be evaluated for possible metastases, and we perform the Whipple procedure, or a pancreatic duodenectomy, where we remove the head of the pancreas, and we remove the gallbladder, some portion of bile ducts, and the proximal duodenum. Clinical findings include loss of appetite, weight loss, jaundice, epigastric pain, a Courvoisier gallbladder, elevated liver test. Sonographically, we would see a hypoechoic mass in the head of the pancreas with dilated common bile duct and pancreatic duct, and an enlarged gallbladder. So here we can see between these two calipers is a pancreatic carcinoma noted in the head of the pancreas. We can have pancreatic cystadenomas and cystadenocarcinomas. These may be referred to as either microcystic or macrocystic, and they can be either serous or mucinous. Serous tumors are small and almost always benign, while mucinous tumors are large and have greater malignant potential. Patients with these masses present later than those with pancreatic head masses and may be initially asymptomatic. Sonographically, we would see benign serous cystadenomas that are small cystic masses that may appear solid and echogenic. Mucinous cystadenomas most often appear as multilocular cystic masses that contain mural nodules. So sonographically, serous cystadenomas are presenting as cystic masses, and they may appear solid, whereas mucinous cystadenomas and cystadenocarcinomas present as multilocular cystic masses with mural nodules and calcifications. There may be associated dilatation or dilation of the pancreatic duct. They can also be islet cell tumors, and these are endocrine tumors found within the islets of Langerhans, and there are two types, gastrinomas and insulinomas. They're slow growing and can be either functional or non-functional. Among the two, insulinomas are more common, and they're usually solitary, while gastrinomas are often multiple. The functional gastrinomas can produce Zollinger-Ellison syndrome. This is the excessive secretion of acid by the stomach, leading to peptic ulcers, while functional insulinomas can cause hypoglycemia, and certain sonographic findings would include hypoechoic masses that contain calcifications, and their visualization is hard due to the small size of gastrinomas. Clinically, we would see low blood sugar levels, or we would see the peptic ulcers in gastrinomas, and we might see accompanying Zollinger-Ellison syndrome. So in the image we have an insulinoma, and this is a hypoechoic mass noted within the pancreas between the calipers. And color Doppler here shows that the mass is highly vascularized. So we can have true pancreatic cysts, and these are cysts noted within the pancreas, and will be seen with von Hippel-Lindau disease, cystic fibrosis, or autosomal dominant polycystic kidney disease. When we are viewing them sonographically, we will see well-defined anechoic masses with posterior enhancement. When we are viewing them, or rather viewing our patients clinically, we would see autosomal dominant polycystic kidney disease history, as well as history of von Hippel-Lindau disease. So in the case of certain carcinomas, pancreatic transplant is in order, and transplantation of the pancreas can occur for a number of reasons. It can be in case to treat severe type 1 diabetes. Techniques can vary, but usually patients will undergo a renal transplant at the same time. So the pancreas is placed within the right side of the abdomen, and the renal transplant is placed on the left. And there are two common types of transplantation techniques. We can have an exocrine bladder drainage and exocrine enteric drainage. And so whenever we have exocrine bladder drainage, the vasculature of the donor pancreas is anastomosed to the recipient's common iliac vessels, and the donor duodenum is anastomosed to the urinary bladder. So we use the recipient's urinary bladder to expel pancreatic secretions, but it is often associated with dehydration and bladder irritation. The other common type, exocrine enteric drainage, occurs by having the donor duodenum anastomosed to a loop of the jejunum. And with this technique, the splenic and superior mesenteric arteries are connected with the donor iliac arteries in what we call a Y graft. And the donor common iliac portion is anastomosed to the recipient's common iliac artery and external iliac artery. And these transplants may be located in the right upper quadrant or on the right side and may have vertical orientation in the body. So sonographically, we want to assess for vascularity and for fluid collections. And the pancreatic parenchyma should be homogeneous and may be hypoechoic. In cases of rejection, the pancreas might appear heterogeneous, and elevated resistive indices are often indicative of acute rejection. In cases of chronic rejection, the pancreas can appear more hypoechoic, atrophic, and contain calcifications. There might be certain fluid collections such as abscesses, ascites, hematomas, or urinomas, or even pseudocysts. And here is an image of transplant of the exocrine enteric drainage. And within exocrine enteric drainage, we have the donor duodenum anastomosed to a loop of jejunum, and we have the splenic as well as the superior mesenteric arteries connected with the donor iliac arteries. As you can see, the abdominal aorta is split into the iliac arteries, and here is the Y graft. There is a zoomed in image representing your superior mesenteric as well as your splenic artery being connected with the donor iliac artery. Thank you for listening.